So with this, we begin our discussion on UIP, IPF and other type of interstitial pneumonias. So to begin with, what is the first thing that is expected of us as radiologists? First question that we should answer is that, is there an ILD or not? Now, this is a very, very important question because whenever you're reporting CT scans or HRCT of patients, you can come across a number of abnormalities like some fibrosis, some nodules, some reticulations. So what is that particular criteria which is good enough to call a disease as an interstitial lung disease? So this is what we're going to understand right now. So we've already discussed the signs of interstitial lung diseases. We'll be again extrapolating them over here. Second important thing, once we have diagnosed that there is an interstitial lung disease, what is the predominant pattern of the disease? We've already talked about different types of patterns like reticular opacities. To begin with, reticulations. Now, reticulations will look like linear opacities. Now, these linear opacities can take the form of intralobular septal thickening, subpleural linear opacities, and we have already described the brief list of differentials for each of them. Or there is nodular pattern. We've already talked about various types of nodules. Just to revise once again, we've talked about centrilobular nodules, we've talked about perilymphatic nodules and random nodules. Again, in terms of nodules, we've also talked about solid nodules and ground glass nodules and what is their significance. That is all what we're going to discuss when we're going to discuss the different types of cases. Third important thing that we've already also discussed is increased attenuation. Now, this increased attenuation can occur as a result of ground glass opacities or as a result of consolidation. And last, we have also discussed a very important thing, that is decreased lung attenuation or mosaic attenuation, which can occur because of either vascular disorders, which can also be seen with ground glass opacities, but can also be seen with small airway diseases because of air trapping. So this is all what we're going to talk about as far as the pattern of the disease is concerned. Then what are the observations that we can make after we look at a particular scan? How will we report that scan in a tangential manner? Then the most important question that is asked of us as radiologists is to differentiate between fibrosing and non-fibrosing ILDs. Now, what do you mean by fibrosing and non-fibrosing? See, ILDs here come with a lot of patterns, specifically the patterns with increased attenuation of ground glassing and consolidation where there's no interstitial fibrosis occurring. Once there is fibrosis like anywhere else, you can see fibrosis in TB also, in infections also, but their fibrosis is usually focal. At the area of infection, the lung parenchyma will get fibrosed and that will result in volume loss of the lung parenchyma. However, in case of ILDs, because it is a diffuse lung disease, ILDs are diffuse lung diseases. They will involve the entire lung parenchyma on both sides. As a result of which, if at all this type of disease goes on to develop fibrosis, just imagine what it will do. It will fibrose both the lungs, and as a result, the patient will have severe breathlessness and severe shortness of breath. So we have to identify whether there is fibrosis present or not, because if there is fibrosis, then we are actually talking about fibrosing ILDs, which have a poor prognosis overall. On the other hand, if there is no fibrosis, we're going to get some ground glass opacity, some consolidations. We can say that this patient is having a slightly better prognosis. Then what are the defining criteria for fibrosis? We've already talked about honeycombing. We have talked about honeycombing. We have talked about a very important or defining criteria, I should say, traction, bronchiectasis, and in fact some reticulations also. Though reticulations can be seen in non-fibrosing ILDs when there's just interlobular septal edema or thickening. But if you see irregular septal thickening, which is admixed with a background of fibrosis, then these reticulations also represent a fibrosing ILD. Then last but not the least, we're coming up to some of the important differentials. If we can answer all these questions in a methodological manner till now, then obviously we can narrow down our differentials to one of those three patterns like UIP, IPF, non-UIP fibrosing ILDs, and some other ILDs which include NSIP, and again a bucket list. We'll be talking about that later on. These terms may be seeming very alienating to you, but trust me, after the entire discussion, it's going to be very easy to differentiate everything from everything else. And finally, as we have already seen elsewhere also, no discussion of a disease is completed without its complications. ILDs also come with a complication per se, and secondly, treatment of ILDs may also result in certain complications that we have to identify and report. So this is the broad framework that we're going to use while we're going to be looking at different cases who are having interstitial lung disease, and this is the same framework that we'll be using to formulate a report for the same. So with these words, let us start our discussion with the first case scenario. So this is a CT cine image. Basically, it's a volumetric image. I'm going to be starting from top, that is from the apices, and I'm going to go towards the diaphragm. So I want you to have a look at this case, and I want you to make your own observations. So I think by now you might have all seen this case in complete totality. Now let me just show you the important observations on this cine image, and then we'll be looking at some of the representative still images from the case as well. So when I'm talking about the apices, do you see any abnormality? Remember our discussion on abnormal pathologies or in ILDs. First is reticulations, look for lines. Second is nodules, look for dots. And third is look for ground glass opacity or increased opacification. Fourth is look for abnormal hypodensity in the lung parenchyma, which may be due to mosaic attenuation. So let's have a look. When we look from the top, I think very easy to identify that there is excessive number of lines in this image. I hope that all of you can see these, there are everywhere. There are lines which are located in the lung parenchyma. So we do have a reticular pattern, and this reticular pattern is taking the shape of interlobular septal thickening because it is more hexagonal. I hope you can see. Not typically hexagonal, but more so hexagonal. Interlobular septal thickening will be much more peripheral and will be much more finer. It will be lace-like or net-like. So let us look ahead. Now here we see that there is some amount of fibrosis resulting in honeycombing type of an appearance. But looking at one image, it is difficult to say. Let us go ahead and go down. And as we go down, I hope now we can see something else. We already looked at the interlobular septal thickening. I want you to have a look here. Now again, there is a fine lace-like, net-like appearance of the reticular opacities in this area. So because these are linear opacities, reticular opacities in a lace-like fashion and very fine, very small, micro. So this is intralobular septal thickening. When I'm going further down, I can see that here there is an area of slightly increased attenuation in the lung parenchyma, probably patchy ground glass opacity. And when I go down further, now is the area of exuberant honeycombing that I can see here as well as here, which is admixed with some ground glass attenuation. There's one more thing. Here, I see that there is an area of cavitation as well in the left lower lobe, admixed with all the other changes that we've talked so far. Now we are seeing that there are some complications to the disease process as well. I want you to have a look here. Now here, the lung parenchymal attenuation is not homogeneous. I hope all of you would agree with me. Look at this lung. It looks completely black, completely lucent. While here, there are some areas which are appearing slightly hyper-attenuating like this, and some areas which are appearing almost normal attenuating. So here, we are having ground glass opacities. That is not focal air trapping because the pathology is in increased attenuation if you compare it with this lung parenchyma, or you can even compare it with the bronchus. We've discussed about the dark bronchus sign. So because it is appearing brighter or denser than bronchus, it is definitely abnormal. It is an area of ground glass opacity. Then as we go down further, again, the diagnosis is pretty certain. Now there are multiple honeycomb cysts which are present. Now, why are these honeycomb cysts? These are honeycomb cysts because we already discussed honeycomb cysts, differentiating them from bronchiectasis, differentiating from emphysema. Honeycomb cysts will be seen as multiple stacked cystic areas located in the periphery, will have shared walls, and they will be seen in multiple layers. They will be seen in multiple layers extending from the pleura up to the center or the hilar region. So you can see that multiple stacks of layers here exactly that you can see, one over the other. So this is nothing but this is honeycombing. That is for sure that we are having honeycombing. So these are all the signs that we could pick up, but one important sign that was left is bronchiectasis. I want you to have a look at this bronchus. Does this bronchus look tapering to you? No. Our definition of bronchiectasis when we were talking about traction bronchiectasis was that should be a non-tapering bronchus. That is, after the origin of bronchus or after the bifurcation of bronchus, even after 2 centimeters, the bronchus does not show any tapering or narrowing. It is a case of bronchiectasis. Secondly, if you see any bronchial structure along the peripheral most part of the lung. So here, if you see here exactly, we can see that this dilated bronchus can be traced up to the periphery. If it is traced up to the peripheral 1 centimeter of the lung parenchyma, it is also a definition of bronchiectasis. So this is classical traction bronchiectasis. Here we can see ground glass opacities also and interlobular and intralobular septal thickening as well. So we have made so many observations. So if you can make all these observations, almost half your work is done.